based on technology in healthcare and emerging opportunities. What are the opportunities in the healthcare sector and how technology can be leveraged to reach to the bottom level. So honorable speaker would be speaking on various topics and bringing their experience and sharing their knowledge on this issue. I'll invite first of all Dr. Pramod Kumar Mahendra, Commissioner cum Mission Director, NRHM, Department of Health and Family Welfare, Government of eODISHA, to share his knowledge and experience in the area of technology in healthcare and emerging opportunities. Sir.
You never know, technology can fail you anytime. Also. Friends, very good afternoon to all of you. And I know it's very difficult to keep yourself awake and alert after a good sumptuous lunch perhaps. Anyway, we'll start with this session, which is a very interesting session indeed. Technology within technology. Medical science in itself is such a highly technical department. That's very until unless you've been worked in the department, you've been very closely associated with the systems of the department. Many a times you don't even understand how it finally works out. There are so many programs, so many ifs and buts, and so many complexities within each scheme that we devise, that finding a technological solution to it itself becomes a very daunting task. We have in NRHM, in Health and Family Welfare Department, I will not just say NRHM is within the department. There are so many beneficiaries and so many service providers that you have to monitor all of them at the same time, starting from, let's say, from village. If we have Village Health and Nutrition Day, then whether on that day how many NC's antenatal checkups actually took place, what was done, was there a quality in the antenatal checkups, the data being entered and then web-enabled, real-time analysis. Then similarly, if you have Gaon Kalyan Samitis, how are they functioning, PHCs, CHCs, have the equipments reached, have drugs reached, are they being utilized properly, is the first in, first out principle being maintained, is there an expiry, how do you take care of all these things, and then obviously management challenges of managing many crises, etc. So there are so many challenges and so many opportunities within the challenges. Since there are challenges, I think at this particular moment of time, if you compare all the departments, very few departments have so many opportunities for ICT applications, IT applications, other than Health and Family Welfare Department. Health and Family Welfare Department, really, that sector, health sector, has lots of challenges, and the challenge today is that all those who have really understood this system should keep on working, because there are many a times we do feel that now going ahead is becoming tough, but really those who have been doing these things, I definitely want them all to keep on working on their missions and see that health actually finally reaches all, because technology is the key to healthcare services. That is the key, and ICT is definitely the key. If we do not develop our systems IT enabled, if they are not IT enabled, then perhaps many things will not just take place. Having given that background for this session, I'll just present one such complex system in health department, which is the blood banks. God wanting, I will wish that none of you go to that blood bank ever, or you don't have that opportunity, be it for yourself or relatives or anybody, to go to that blood bank. But having said that, it is something that we can't escape. Every day there are so many things happening around which require, those situations which require blood transfusion. And therefore, just to take you through, because many of you may not be knowing what a blood bank is, like, I'll just take you through the system itself. First of all, why do we need blood. Why do we need blood is very clearly pointed out. Most of you are intelligent enough. I'll not go through this slide. The reasons are known, and these are very, very important reasons, starting from hemorrhages to accidents to anemia to dengue. Dengue is an emerging disease where you require blood components, platelets. Then patients suffering from severe hemorrhages, etc., and so many diseases that we come across every day. Now, the issue is that the blood is not manufactured anywhere. It's just manufactured in our bodies, and that it has its own shelf of life, which is being debated. Even today I was going through an article. Earlier the shelf life was defined as 6 weeks, but now there has been some research in London. Somebody has conducted that research, says no, it should be only 3 weeks. So, which means people are working towards quality of blood transfusion. That quality blood is available, quality blood products are available, because once it is given to a person, he should not, the blood transfusion itself should not become a problem for him. He is already in a deep problem. That itself should not become. But the bigger challenge than the quality itself, that quality, how you maintain quality and how do you address that quality issues through ICT, that I'll let you know through my presentation. But a bigger problem is that many times you don't even know that this blood is available or not available in a blood bank for citizens, common citizens who do not understand the niceties of the entire system. They want blood immediately. And that is where those who have read economics, that is where the scarcity is sometimes created artificially. Perhaps because of self-interest, perhaps some people have a rent-seeking behavior in the system. They create an artificial scarcity. So how do you get away from this? That you can beat only through an IT solution. This is what the aim of this entire presentation is. So, having said that, from whom it is safe to take blood, that screening is done. You collect it sometimes in process it, test it. There are 5 mandatory tests that you have to carry it out. It is not safe at all. How do you find out whether that 5 mandatory tests, checking all the records, is just not possible sometimes. You can just enter it has been done and you put it in the fridge and it's gone. And next it is transferred to somebody and you never know that you have to do this cross matching. Then you obviously, if it is compatible, then the seropositivity rate is also going. So whether the quality blood transfusion is being done, quality blood is being collected, becomes very, very important. Now, blood transfusion services prior to e-blood banking, most of this I have already covered. The constraints and challenges are these. Public has no easy access, I told you. Sometimes artificial scarcity is also created. There are manual donor screening, as I told you earlier. It's done manually. The levels of operation are there at multiple sites, and therefore sometimes equipment failure could be there due to variation in laboratory procedures. How do you maintain that SOP? For every equipment there is a SOP. Whether that is being calibrated every now and then at a regular interval, sometimes you cannot know. Then there are issues related to testing kits and reagents. There are manual errors that could actually creep in. There are inaccuracies in the recording or transcription. Naturally, humanly, it's not possible always to keep track of all these things. So e-blood bank, with this background of the system and the problems which were there in the manual system, we wanted to minimize all these gaps through IT automation, complete IT automation, which starts from the donor to availability of the blood to the common citizens. The additional inputs also were then incorporated in the system to improve the quality and to standardize blood banking services. We saw it as an opportunity for doing many things which we were unable to do. To standardize blood banking services, to have SOPs, clear SOPs, to also link it with licenses. Licensing of blood banks is also very essential. At regular intervals they are checked, and the blood banks know that this is my date of renewal. but they are unable to get into the system. That is a different set of system where you get your license and then you apply. You do not know where my license is, when will it come, when will they come for joint inspection, etc. This was an opportunity where we could also link it with the licensing system. And then web-based camp management also. And each equipment, as I said, working status also we can find out. The e-blood bank life cycle I have already told you, I need not go through it again. So these were the enhanced modules through e-blood bank. These were the envisaged modules through e-blood bank. To consumable inventory management system is something that we wanted to do. We wanted to also have an asset management system. We wanted to have a bio-waste management system, a blood supply chain management, employee information management system, and a blood bank license management system, the last one that I told you. Integrate all of them in e-blood bank. That's e-blood bank having several systems, subsystems in it. So these are the 4 advantages from the at some point I have mentioned all of these. Process automation, the entire process gets automated. Complete automation. Quality and standards are maintained. Management of the entire system of all records of the human resources, and provide citizen-centric services also. So we now have a dashboard for blood bank officers, tested, untested, buffer stock. These are the entire process automation allows that. And I'll just show you which is the blood group number reserved. Everywhere, whole blood or whole buffer level, stock level, everything you will know. The single source entry for documentation, easy tracking of patients. These are all there in the process automation on the dashboard of the blood bank officer. The quality and standards are also maintained. There is an optimal utilization of the blood units before expiry, as I told you earlier. It has its own life cycle. So you have to use it before that. If you do not use it before that, then it is a wasted blood and it has to be destroyed, which you sometimes read in newspapers also, at so and so blood bank, so many units were destroyed and all. It is because we do not optimally utilize it. We do not know that it is going to expire and that there is a blood bank where this same blood group, these numbers are required, but it doesn't have. Can you transfer it to that blood bank? So that that blood bank which does not have it will utilize it within that given period of time, and you will not be compelled to destroy it later on. This is something that we wanted to do. Then donor screening using unique identification codes through biometry. Donor deferrals at different stages. Ensure 5 mandatory tests, as I was mentioning earlier. And tracking of validation of kits and reagents as per their SOP. Asking, how much do you have? Then he will say, I think I just had one and somebody took it away, and says, sir, how do you, I have to get it? Okay, then I can find out. There could be 2-3 left, but it's difficult. That must be in buffer stock. So somehow when it comes, then you know the rent seeking is taking place. So this he cannot now, right now can do. Any of you who want to try any of these 3 systems right now, which is one is IVRS. If you dial 180034577747, which is a toll-free number, you will be led through that voice call to give your STD code of the district where you want to know this blood group, and finally give a blood group code which they will guide you through. This is IVRS system. The second one is easily, you can right now do it easily. Through SMS. If you don't have a BSNL mobile, you can do it through 56767. If you have a BSNL, then you'll do it through 54323. So you first type all in caps ODBB, give a space, then the first 3 characters of the district where you want it, and then give the space, the group that you want, A, B or O, whatever, whichever you want, and then again give a space. And depending upon whether that is positive or negative, you will write E or N. Immediately it will give you the number of blood group, the blood units which are available in all the blood banks in that district. So if I would say Sambalpur, it will give you Kuchinda, Sambalpur DHH, everything it will give you. So if somebody would like to test it? Any questions on this? done, but the tests are done later. But if you come for a replacement, maybe tests and all, it takes time. But there are different other methods also which you can do a preliminary screening through rapid test. Rapid test is something that we are not allowing now because that is not non-specific. But the specific test, if you take, it will really take time.
So is the donor being, so if there is a problem with the blood sample, so if the donor being said that reciprocated that message and all?
Yes, that's what deferral is.
Okay.
I mentioned about deferral, donor deferrals. So when the donor has given his blood and the 500 tests are done and it is found that that blood cannot be accepted, it is told to him that your blood is deferred. It's not accepted. Screening properly the donor. That is what we want to avoid through this automation of giving smart. That maybe you can discuss. That's not related to e-blood. This is separately done.
Any other question?
On e-blood bank.
E-blood bank.
The IVR system is not working.
It is not working?
I have tried 4 times.
Will somebody come and do it? Guru? SMS भी नहीं करो नहीं. IVR is the which district
For
did you?
ordinary people, this IVR system is more convenient.
Yes, I
For
will.
the
777 अपना मैसेज करन. मैं मैसेज नहीं कॉल करन. It's not message, call करन. It will guide you through everything. It will tell you.
Sir, I have a question. Mr. As the second largest population of tribal matters to all. So what is your take on them, how they are going to be benefited by this? Because they are diverse people and we have to protect them as per their diversity. So do you have to say anything on that?
See, insofar as these areas where tribal populations are more, anemia cases are more, even severe anemia, we get pregnant mothers who are severely anemic at the time of delivery. These are the cases, these are the patients who require blood very frequently, and with this citizen-centric services, they need not actually wait for somebody to tell them whether it is available or not. Second thing is, we have a program which is called JSSK, which is Janani Sishu Suraksha.
Now I would like to invite Dr. B.N. Mohanty, Honorary Secretary, Telemedicine Society of India and Head Experimental Surgery, SCB Medical College.
Commissioner, Mission Director, NRHM, friends, distinguished guests, ladies and gentlemen. India is growing fast in technology application. One of the major areas where it has really made a remarkable impact is the use of telemedicine technology for augmenting, for enriching the quality of medical care and health education in this country. Telemedicine Society of India is a non-profit making academic body working towards population of the technology and for wider application of telemedicine both in health sector and medical education. Today, I'll be talking on the telemedicine activities happening in the state of Odisha, because Odisha happens to be one of the leading states in telemedicine technology application. We have the major chunk of this population staying in the remote areas, and this technology can make a difference in optimal utilization of the available medical resources. second area, possibly one of also the leading areas in telemedicine technology application, is education. We have been using this in most states of this country. As you know, this country has more than 500 telemedicine nodes established by the Ministry of Communication and Infrastructure Technology, Government of India, the Ministry, that means the Department of Space, and also the state governments, through interactive virtual classrooms, through conferencing and through telementoring and teleproctoring. And finally, possibly we are entering to the age where we will be using more often this technology for telepresence or presentation. As I said, this picture shows that you have an expert on the left side at Sanjay Gandhi Postgraduate Institute of Medical Sciences, because the medical college hospitals of the state of Odisha are connected to Sanjay Gandhi Postgraduate Institute of Medical Sciences. And the government of India in fact has identified 6 regional telemedicine resource centers. One is PJ Chandigarh, second is AIIMS New Delhi, third is Sanjay Gandhi Postgraduate Institute Lucknow. Then you have KM Hospital Bombay, then we have one at Pondicherry, and final one at Nigrim Shillong. So these are the 6 regional telemedicine resource centers, and the states are linked to this regional telemedicine resource centers. We have been using regularly this for obtaining second opinion in situations where there is really a difficulty for the expert in making a diagnosis or planning the management. Then the follow-up. For thyroid cancer, we have the operating facility in the state, but the second part of the treatment of a patient thyroid cancer is radioiodine therapy, and this facility is still today unavailable in the state of Odisha, and patients after treatment are referred to Sanjay Gandhi Postgraduate Institute for radioiodine therapy. And these patients, when they are declared disease-free, receive the same facility as they would have got if they had gone there for follow-up, for getting follow-up advice. So this he was using regularly. We have more than 300 patients of thyroid cancer who are on regular follow-up at SC Medical College, Cuttack. So this is how every Wednesday, first and third Wednesday, we hold this clinic at Cuttack, and we have the teleconferencing facility. We use the teleconferencing facility or video conference facility for seeking advice of the remote expert. Then remote treatment planning. Sometimes we have patients who are critically ill. They come to district headquarters hospitals where they fail to plan the treatment, and in those situations they take the help of the experts of Cuttack Medical College or Burla Medical College, Berhampur, to plan the treatment for patients who cannot be transferred right away from the district headquarters hospital to medical college. Otherwise they will succumb on the way. So this is a patient the patient was attacked by a wild bear, and both the windpipe, food pipe were exposed at this. They kept on advising him, the remote expert at Koraput District Hospital, how best to manage this patient with the facilities available there, and the patient was saved without being transferred to medical college hospital. So this is extremely essential, particularly in emergency situations. Pre-referral screening. Many patients who are referred either from district headquarters hospital to medical college hospitals or from medical college hospitals to super specialty hospitals in Delhi or in Lucknow or in Chandigarh. And it is essential that all these patients before referral should be screened, so that you know which are the patients really need to refer and which patients do not. Because many patients from district headquarters hospital are straight away referred. The moment they reach the district headquarters, they refer to the medical college hospitals. So that unnecessarily increase the load on the medical college hospitals. The best way is, as is happening in Punjab. In Punjab, unless a patient has pre-referral screening, he cannot be admitted to medical college hospital. That is a rule they have made in Punjab. So similarly, that it should be this rule should be there in every state. The patients, unless they have prior screening, should not be referred to medical college hospitals, because many patients who otherwise can be treated there with regular advice getting from the experts of medical colleges through video conference. Then the other area I told you, education. So these are the regular classes of postgraduate students of medical colleges being held, and where experts or the professors of the Sanjay Gandhi Postgraduate Institute, or at times also of Orient Institute of Medical Sciences or PH Chandigarh, they take classes for students. Now which are the areas? There are many areas where do not have competent teachers but do not have study material available. There are some new departments which are not yet, we have not started this department in the colleges and practice in district headquarters hospitals. They think that possibly they are out from mainstream, but by having regular sessions with them, they do not feel they are away from medical colleges, and they developments and their experiences. These are the medical classes, distant medical education classes being held in medical colleges and the experts in the super specialty hospitals at Lucknow and Delhi taking classes. Skill promotion workshops, sometimes operative surgery workshops. Many times, as you know, doctors need updating in recent surgical procedures. Now they have to go to city-based hospitals or go to super specialty hospitals to attend workshop to know what are the new technologies in different or techniques, in operative techniques. But if you have the telemedicine facility and a high bandwidth, as we have now NKN, National Knowledge Network, has provided 100 Mbps bandwidth to all medical colleges, 3 medical colleges of Odisha, and even also to the private medical like the KIMS and to some medical college. So they have also got high speed bandwidth. So we have got 100 Mbps bandwidth and we are using it for transmission of the operative procedure right from the medical, from the operation theatre of the super specialty hospital to our colleagues or our faculty members. So I think possibly we are in a time where we do not need every time to go to a conference or workshop to see what is happening. We can stay here and interact with them and see the procedure if you have high bandwidth, which we have now. So this is what is known as telementoring. Telementoring in fact is real-time interactive teaching of operative techniques by an expert of surgeon to a student not at the same site. So this is telementoring and we are using this technology for telementoring. A number of conferences which are held in different places are being transmitted live to the medical college hospitals where the faculty members here or participants here do interact live through two-way audio and two-way video. Where Paju was telling that we are possibly entering a age where we can use robots for robotic arms. Our robotic medical robots are not the robots which you see in physics. We use robotic arms for performing different surgical procedures. There are a number of robotic equipments available now in many hospitals of this country. However, we have not used this for tele-robotic surgery, but maybe soon this country will use this for tele-robotic surgery. So maybe in the surgery in future will be no longer about blood and tissue, rather it will be about bits and bytes. And a little bit about the telemedicine activities that is happening in Odisha. The Odisha Telemedicine Network was established in 3 phases. In phase 1, that was in 2003, when the 3 government medical colleges of the state were connected to Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. That was 2003. And then looking into the outcome of the where regional diagnostic centers came up, because CT scan and ultrasound machines were installed in those regional diagnostic centers and where we didn't have experts. So we thought and so on and so forth. So and how the state has been benefited by this use of telemedicine technology. Now this benefit has been to the patients and to the students and to the teachers. Benefit to patients. So around 3 the pathologist or the radiologist wanted second opinion. So this has been used for reaching at a diagnosis in difficult clinical situations, planning the management protocol of critically ill patients. And then second opinion, sometimes pathologist seeks second opinion for a pathological slide where he fails to make a conclusive diagnosis and then comment on CT MRI filling, particularly the difficult patients. So these are situations where the patients have benefited. Then benefit students. So students have been benefited, as I told you, that in certain areas where we have like departments, rheumatology department came up recently only at Cuttack, but there are many places, Bulla, Barampur do not have department of rheumatology. So these are certain areas like rheumatology, genetics, nuclear medicine. So these facilities are non-existent in the state and we take the help of the students. By interaction in these areas, they get benefit. So more than around 2,200 teaching topics have been discussed between the students and the experts of the medical colleges or remote hospitals, particularly the super specialty hospitals. So they get the advantage of getting access to not only the teachers of that particular medical college, but also nationally reputed teachers. Benefits to teachers, medical professionals, that helps, as I told you, the upgradation of the professional knowledge and also the technical skill. Now recently government of Odisha is taking the telemedicine to the reach of common man through the public-private partnership, which you will listen later. And so to conclude, I would like to say that telemedicine offers easy, cheap, fast, at any time and from anywhere contact between the medical staff and the patients. Accepted well, it may cause significant reduction of the part of the healthcare budgets. it is not a replacement but a complement to the face-to-face examination. So that we are emphasizing that to say everybody, if you say that your telemedicine cannot replace the face-to-face examination, never say it is a replacement. It is always a supplement, a complement to the existing traditional face-to-face examination system, which is there and which will continue to remain there. Then the single most important principle of medical care is to provide satisfaction to the patients. And if the patients get satisfied, so for example, as I was telling that follow-up, now every time the patient has to go for follow-up every 6 months to Sanjay Gandhi, it will not only cost him money but also loss of time. Now if the patient sees the expert who treated him at Lucknow through video conference, then that gives a satisfaction. That is what is required in medical science. The patient must get satisfied by he looks at the surgeon or physician who treated him, he describes to him, and then that is he gets solace from him. That gives him satisfaction. That is essential in medicine, and that we provide through video conference. So friends, I think this is all about the telemedicine activities happening in the state, and as I told you that this has really made a difference in promoting, it has proved to be a useful tool in not only promoting the quality of healthcare but also medical education in the country as well as in the state. Thank you.
Have any question for us? You can ask.
MBBS, and from medical college side we were having 2 MBBS upload back this Bangalore.
Any other question? Yes.
So what kind of software do we use for this kind of work? And second question is, if we have to establish this kind of a setup in a medical college, how much does it cost?
First is the software. We are using actually 2 or 3 softwares. So one is televital. Then we have also involved CDAC Pune to implement our telemedicine project where we are using Mercury software. Some time back also we have used Sanjeevani and eSanjeevani, that was which were developed by CDAC Mohali. So these are all the softwares we are using for telemedicine activities. Now as regard the cost, you are saying that the cost varies from 4 lakhs to 18 lakhs. So depends what are the equipments you need, either in a medical college setup or a district per setup or a rural center. So depends, are you going to develop and use a economic model, are you using a full face all equipments, scanner, everything. So depends on all these things. So the range varies from 4 lakh to 18 lakh.
Training.
Good afternoon, everyone. My earlier speakers have already made it very clear the use of technology for the telemedicine network done by the state. Odisha is the first state in the country to take it, to connect the medical college to district level. Subsequently, now they have connected to all district hospitals. Then OTEC telemedicine came to take it further to the grassroots level, for which, as my earlier speaker have said, that on a PPP mode, now we were to take it further to the remote village level, where the medical facilities to be provided. Earlier speaker about the telemedicine, how it can be done for pre-surgical, post-operative, teleconsultation, ICT has got a big role to play in this for provide healthcare services at the village level to cover 51,000 villages of the state. What is more added in this, as the unemployed youth having +2 or the OSS program, having computer knowledge, are being trained as accredited telemedicine technicians. They are provided with the telemedicine equipment like for taking the vital parameters starting from height, weight, BP, SpO2, so on, and they take the vital parameters and then they transmit it to a doctor point where the doctor, after going through these details, interact with the patient. And all those accredited telemedicine technicians are from the local village, from the local area, so that they can interact with the doctor in the language, because the language barrier is there. So local people are being trained, and that helps in a bigger way when it is doctors are real scarcity or doctors are not available in the villages. Then the specialist, the same thing happens to this. As all of us we know, there is a big mismatch, doctor-wise and facility-wise. What to speak of rural, even in urban. So telemedicine has got a bigger role to play in this, in bridging the gap of demand-supply mismatch, doctor-wise and facility-wise. Odisha perhaps the first state to take it forward to bridge the gap of demand-supply mismatch, doctor-wise and facility-wise. So suppose doctor, if it is possible that a first aid or some treatment can be given that is provided for prescription, which is transmitted to the patient. If not, being advised to go to a nearby hospital or CSC or PSC. So what is the uniqueness of this program of PPP mode? It is going to be connected starting from medical college to sub-center level. So that from a sub-center one can reach to the PSC or CSC. As per the need, he can consult a doctor immediately. If from there it is required, he can go to district level, or as per the advice of a doctor, he can, besides that, he can consult to a super specialty hospital. So this is about the outpatient. In inpatient also the same thing has been done. So that in a CSC, PSC, OTEC have partnered with besides the medical college, the group hospitals like Apollo, Narayan Hidale, global group of hospitals, Asian Institute of Gastroenterology, many more. These are the group hospitals already linked. And apart from it, AIIMS Bhubaneswar also have agreed to provide consultation to the rural people at this point of time. Further assistance also is going to come from them. Apart from this, the health camps are being organized in the village areas, which helps in preventive care. So where Government of Odisha also have decided, that is, in the NRCM program, also these telemedicine facilities are going to be used.
Thank you so much for your wonderful information. Now I would like to felicitate our speakers. I would request Mr. Pramod Kumar Mahendra to felicitate Dr. B.N. Mohanty. Can we have a round of applause for him? Now I would request Mr. Pramod Kumar Mahendra to felicitate Mr. K.N. Bhagat. Now I would request Dr. Pramod Kumar Mahendra to felicitate Professor Praveen Mohanty. Now I would request Dr. B.N. Mohanty to felicitate Dr. Pramod Kumar Mahendra. Thank you so much, Honorable Speaker, for your wonderful session and presentation. We will begin with the next session, and I would like to invite, we'll take perhaps 2-minute break, and I request everybody to be seated.